Lovely. Hello, everybody, and welcome to another one of our fabulous MAG Educational Specialist Seminars. Today we have with us the very lovely Kristi Gilbert, who is a critical care registered nurse. She's got about 30 years of clinical experience across multiple areas of nursing, including ICU, ED, anaesthetics. She's done a lot of medico-legal work. She's done community nursing, wound care, aged care, and nursing management. She's been involved in legal nursing commentary and reporting for at least 5 years, and she writes an outstanding report. We are very pleased to have Kristi with us on the MAG team. And if you would like to know anything more about her, you can contact us for her CV and a sample report. I think we have those. But she's excellent. Today's talk is really interesting, and it's something that we see quite a lot, not just in the medical negligence space, but in a range of different areas within medico-legal. And that is the failure of, in particular, nursing staff, but hospital staff generally, to identify aspects of deterioration and follow the appropriate clinical pathways, which can have catastrophic results. So I'm going to ask if everybody could please keep yourself on mute throughout this, but at the end of the session, there will be the opportunity to ask questions. If you have to go and you have a question, please just type it into the chat and I'll make sure that it gets asked for you. The recording will be sent out to you within about a day. And of course, all our recordings are available on our YouTube channel. And if you have a login to the MAG Connect platform, just click on seminars and it opens them all up for you. Thank you so much. And without further ado, over to you, Kristi. Thank you so much.
Thanks, Michelle. I'll just share my screen. Can you see that? I'll just try again. Is that working, Michelle, when I shared it?
I'll just go and grab Sophia.
Yeah, no, technical error. It was working before.
Yes. Hang on 2 ticks. Sophia has ducked out.
I'll just try again now.
Oh, there we go.
Is that now it's working? Yeah, it's finally caught up. That's right.
Beautiful.
I'll just go. Can you see that now?
Yes, I can.
Excellent. Lovely. All right. Thank you so much for having me. Feels like yesterday that I started my nursing career, but it was 30 years ago this month, which is hard to believe. I've been fortunate in that time to have worked in a variety of areas, but my main area of expertise is acute medical and surgical nursing in intensive care, emergency department, anaesthetics and aeromedical retrieval. And COVID kind of changed my life in terms of my career. So I've moved into community nursing since then and predominantly now work in palliative care, aged care in community nursing and wound care. So it's a pretty big change of scenery for me, but it's been a really interesting journey. So I started working as a legal nurse consultant about 5 years ago. And in that time, I've done over 70 medical negligence reports, looking at how nurses' inaction or actions have caused or contributed to a person's injury. So in that time, there's been some recurring themes that I've come across around informed consent with iron infusion stains and failure to follow protocols when people complain of pain at IV sites. Falls is another common one that I see, resulting in injury or death where falls prevention strategies have not been implemented. Wound management is another big one that I'm seeing a lot of now, with failure to provide appropriate management of wounds. And the other one that I see a lot of is failure to recognise and respond to clinical deterioration, which is obviously why we're here today. So I want to talk about that in a bit more detail and how it might apply to a medical negligence case. And we'll look at a couple of recent case studies that have been in the media. You may recognise the cases, but I have de-identified them. They've been highlighted in the media. One's had a coronial investigation and finding released. And it all relates back to standards of care and failing to provide a safe and high quality level of care for patients. So It's obviously always tragic when an unexpected death occurs in hospital, especially when those deaths might relate to children. And they're the two that we'll look at today, both deaths of children in ED, in hospital, sorry. One was in an emergency department, one was in a ward. But what if those deaths could have been prevented is really what we're looking at. And the deterioration that goes unnoticed by nursing staff when they've failed to notice what's going on or failed to listen to the concerns of family members when their family members' concerns are dismissed or ignored. Because this is a scenario that's faced by some families who have been in the Australian healthcare system in the past few years. So the first case we'll look at is a 7-year-old girl called Ashley. She'd been unwell over the Easter holidays in 2021 with a viral illness and a headache. She'd spent the Friday resting, a little bit of vomiting, nothing too severe. On the Saturday morning, she was more unwell, started complaining of body aches, fevers, had cold hands and a warm head, and mum and dad were a bit worried, so they decided that they would take her to their local children's hospital. So they arrived at about 5:30 and explained to the staff that she'd had this viral illness, that her hands were cold today, her head was warm. She was seen immediately by the triage nurse and given a category 4, which is semi-urgent and likely to be seen within an hour, ideally. And the triage nurse felt that it was likely a viral type gastro picture and placed her in a waiting room. When the parents entered the waiting room was quite full, and there was a sign on the wall saying that the wait time was likely to be 4 to 6 hours, and that any kind of inappropriate behaviour wouldn't be tolerated. Obviously, when there's a long wait time, people can get frustrated and angry. The family noticed the sign on the wall and were worried about how long they'd have to wait. And so Ashley's mum approached the ward clerk, concerned about the look in her daughter's eyes. The ward clerk obviously took these concerns on board and spoke to a junior doctor who didn't have access to the file at the time because the notes were just being prepared. He went and had a look at the child, thought it was just about the eyes, looked at the eyes, they looked normal. Because he didn't have the notes available, he was unable to make any documentation about seeing the patient, and he was unaware of the presenting complaint. And so he just assumed that she would be seen within a timely manner and said that there was nothing to be concerned about in regards to her eyes. The mother didn't have her concerns alleviated, I guess, and so she went back to the ward clerk after the doctor had left with ongoing concerns about her daughter's condition. Her daughter was becoming more lethargic at this time, and the ward clerk spoke to one of the nurses in the waiting room who agreed to go and see Ashley and talk to her parents given their level of concern. So this was at about 5:50 p.m. It's only about 20 minutes after she presented. The nurse had a student nurse with her. She was also the nurse who saw her was quite junior. And they came and took some clinical observations, which the nurse felt were not immediately alarming. She didn't, however, document them at the time, but she did make a plan to give Ashley some oral fluids and some ibuprofen. Unfortunately, before she could document her plan either, she was called away to help with a resus, and so nothing was documented about what she'd done. The nurse eventually had an opportunity to document the vital signs at 6:45, so almost an hour later, and the blood pressure was recorded as 114 on 103, which is an unusual reading, and I would suggest was probably inaccurate. The respiratory rate was documented as 44, which is quite high. Temperature's obviously high at 38.8. Her heart rate was extremely high at 150. Oxygen sats were 98 on room air. They were normal, but none of these vital signs were escalated to either senior nursing staff or medical staff at the time. So the nurse didn't realise the significance of those vital signs, and obviously so she didn't escalate them. And unfortunately then she was asked to go on her break. And so she handed over to a relieving nurse the plan for fluids and ibuprofen. And even though the observations were then documented, the other nurse hadn't looked at them and wasn't aware of how unwell the child was. During this handover period, the mum approached the desk again, expressing concern, and the relieving nurse brought the drink and the Nurofen to Ashley to take. When she got there, the parents were trying to assist Ashley to take them because she was too unwell to take them herself. And the nurse wanted to let the patient do it herself. But obviously, when she couldn't, the nurse realised that something was wrong. And finally, she went and spoke to her senior doctor to get a medical review. The doctor came at 11 minutes past 7 to see Ashley and requested that she be taken into a treatment room for observation and a thorough assessment. But it took about 20 minutes for them to find a room to take her into. But once they got her in there, they realised, the nurse that was looking after her then realised how unwell she was, and she was deteriorating quite quickly. She was taken to a resuscitation room where she had a venous blood cast done, and it was found that she had a severe acidosis and a lactate of 12. A normal lactate is usually kind of less than 1 or 2. So she was quite unwell. They did start giving IV antibiotics and IV fluids. She had low blood sugar and got some IV dextrose, and they were preparing to intubate her when at 20 past 8, Ashley had a large vomit and went into a cardiac arrest. And despite extensive resuscitation, she was unable to be saved, sadly. And her time of death was 9:04 p.m, so only several hours after she'd arrived in the emergency department. So obviously, given that this was an unexpected death, she had an extensive postmortem with the coroner, and they found that Ashley had died from fulminant sepsis from a bacterial infection caused by Streptococcus pyogenes, which is a group A strep, which is often fatal without early antibiotic treatment, especially in children, and it can be difficult to diagnose, but there were obviously clearly signs of sepsis in Ashley by the time she arrived in the emergency department. So an inquest was held in September of last year to determine whether or not Ashley's death was preventable if she'd received earlier medical treatment, as well as considering other issues from a public health perspective. There'd been other issues at this emergency department at this hospital over the time it had been open. So it was of interest to the coroner to determine if there was a sequence of events that were in place that could have been prevented. The hospital also did a root cause analysis, and then there was also an independent investigation into the circumstances, and the coroner considered all of the findings and determined that there were many missed opportunities where the deterioration could have been recognised and escalated, and it may have prevented the child's death. So we'll talk about some of when those opportunities occurred. So the first one was obviously at triage, where no observations were recorded. It was obviously an important time where they could have found some abnormal observations at the time and escalated care more quickly. But I guess COVID kind of had an impact on that, where people weren't being physically assessed because of the barriers put in place between triage and patients, physical barriers to prevent transmission of COVID, even though there were no COVID tests done on the child to determine if she was COVID positive at the time. So there was a missed opportunity by the first doctor who saw her, even though it was limited because he didn't yet have the notes available. He didn't speak to any nursing staff to find out what her symptoms were or check on the computer system, which would have been there. And there was a miscommunication between the mum and the ward clerk, and then the ward clerk to the doctor, of what the actual symptoms of concern were, because it obviously wasn't just her eyes. There was a missed opportunity for escalation by the waiting room nurse. This happened a few times where her observations obviously weren't entered into the chart. And we'll talk more about the way that the observation charts are set up to detect deterioration. So had they been entered in, they would have been flagged as abnormal, and potentially the sepsis pathway could have been commenced earlier. But the nurse failed to recognise the signs of sepsis in those abnormal vital signs. The other problem with the waiting room nurse was that she was a junior nurse. She had a student with her preceptoring, which places extra stress on her. It was a very busy department. She had multiple competing duties. She was assessing patients in the waiting room. She was explaining wait times to families, which is obviously a lot of them. She was helping in a resus, so she was getting called away to perform other duties. And she had the care of about 20 to 40 patients in that waiting room at any given time throughout her shift. So the fact that she didn't document those observations, she didn't write her plan down until after her breaks. Other nurses were unaware if they'd have picked up the chart. The fact that she was called away to a resus for almost an hour led to a delay in those vital signs being repeated or acted upon. And the relieving nurse who took over from her break was unaware of those observations. So the coronial findings were basically that if that abnormal observations taken at 5:50 by the waiting room nurse and the clinical symptoms of lethargy and peripheral shutdown had been recognised and escalated, the sepsis pathway would have been implemented earlier and Ashley may have survived, and that she had an unavoidable delay to her treatment due to failure to recognise severe sepsis and escalation of care with a rapid deterioration and delayed commencement of IV antibiotics. So a pretty sad case. The second case we'll look at is a little girl we'll call Emma. She's an 8-year-old girl who became unwell in April of 2022 with abdominal pain, vomiting and fever. She had been at home for a couple of days like this before her parents decided to take her to the GP. She just wasn't getting any better. The GP suspected that she might have had appendicitis and recommended that they present to their local emergency department, which was a children's hospital specific ED. It was really busy. They waited about 2 hours to be triaged. So no observations during that time at all. When she finally was seen in the department, I'm not sure about timeframes, this one hasn't gone through the coroner's court yet. She had an abdominal ultrasound at some point in time, which showed that it was likely not appendicitis and that they felt it was probably a viral gastroenteritis instead. So about 9 p.m, she was given some treatment, some IV fluids, and shortly thereafter, she started complaining that it was hard to breathe. So they were her words, hard breathing. Her mum used the call bell to call for staff assistance multiple times, and after about 30 minutes, she had no response. And so about 9:30, mum went out to their nurse's station to get assistance for her daughter. About 9:45, the nursing staff came and examined Emma. It's unclear what they did or what her observations were, but she was told that she likely just had an empty stomach after having 2 days of no food and that there was nothing to worry about, that they didn't feel that there was any concern over her breathing, and that she was probably going to be discharged in the morning and only being kept in for observation overnight. The nursing staff did eventually, at some point in time, tell a doctor that she'd been complaining about having hard breathing. And at 3 a.m, a doctor came to take some bloods and they had an ECG done at the same time. The ECG was abnormal and the bloods were abnormal and reviewed, but felt to be falsely elevated. So nothing was done about them. About 6 a.m, with mum constantly kind of reporting that she was concerned and having her concerns dismissed, they moved her to a short stay unit. When she got there, the nursing staff realised how unwell she actually was. And soon after, she went into cardiac arrest. She was able to be resuscitated initially, but she kept going into cardiac arrest and eventually died at 10:17 a.m. Her cause of death after an autopsy was found to be lymphocytic myocarditis, which is a viral illness which attacks the heart muscle. So unclear at this stage, given that there's been no coronial investigation, whether or not her death could have potentially been prevented, but the hospital did do a root cause analysis after the death and found that the abnormal ECG done at 3 a.m. was misinterpreted by the doctor. The blood tests from 3 a.m. were known to be abnormal, but were dismissed as being falsely elevated. And that staff had been failing to assess the level of parental concern, which is supposed to be done every time the vital sign observations are done or any time the parents express any concern. But that concern kind of wasn't taken seriously. So the results of the root cause analysis were basically that they had failed to appropriately monitor the vital sign observations at regular intervals. So they were done, but not regularly enough. That their nursing staff had failed to escalate some low blood pressure readings. I'm not sure exactly what they were, but they were low enough that they should have been and weren't escalated. And the hospital felt that there was a missed window of opportunity between 3:30 a.m. after the blood results were back and 6 a.m. for her to have been transferred to a larger children's hospital for consideration of ECMO, which is a life support machine. So in light of those tragic deaths, we need to examine the way that nursing staff recognise and respond to clinical deterioration. The early identification and accurate documentation of clinical deterioration, followed by a prompt and effective action, because the two need to go hand in hand, is vital when you're trying to prevent serious adverse outcomes such as cardiac arrest and unexpected death. Those events are usually preceded by observable physiological and clinical deterioration. And I guess that's what we've seen in those two cases, that there were obvious signs that were missed by either poor communication or poor documentation, or just failing to recognise the signs altogether. So in around 2010, when we transitioned to national registration, there are a lot of changes in the healthcare system in terms of having a national standard of care rather than state-based standards. So the health ministers got together and endorsed the first edition of the National Consensus Statement for essential elements of recognising and responding to clinical deterioration, which basically provides a consistent national framework for recognising and responding to deterioration in Australian hospitals. So the consensus statement focused on making sure that there was a safety net in place for patients and that staff knew what the expectation was in terms of recognising a deteriorating patient, and that there's systems in place then to support staff being able to escalate. It's kind of been a historic thing in nursing where nurses might be concerned or they might see some deterioration, but it's might be in the early stages, and that the only avenue previously to get any help was either to call a doctor, which there was no way to kind of express the urgency of how serious it might have been without going to call a code blue, which is obviously a medical emergency response, usually saved for people who are in a life-threatening situation like a cardiac arrest or a prolonged seizure or something. So this national standards kind of set in place some better responses and layers of response so that there was clear framework in place to be able to escalate concerns without feeling like you were being overdramatic and calling a code blue when the patient wasn't in cardiac arrest. So the national statement basically led to the recognising and responding to acute deterioration standard, which is part of the National Safety and Quality Health Service Standards and is now a nationally recognised standard across Australia in all clinical settings of nursing, whether it be hospital or community. So the standard basically sets out the warning signs of clinical deterioration and how they can be missed, and then gives some hospital strategies for when they're developing policies and protocols for making sure that those things aren't missed. And they're often influenced by organisational and workforce factors such as not performing clinical observations consistently or at set intervals, lack of knowledge by nursing staff of the signs and symptoms of clinical deterioration, because that can be caused by multiple diagnoses, lack of formal systems when responding to deterioration, and failure to communicate clinical concerns. And this might be things regarding like change in patients' behaviour, such as increasing delirium, which can be a precursor to more serious conditions, especially in the elderly, and lack of skills to manage patients who are deteriorating. So the clinical deterioration standard, which everyone has to follow, highlights 9 essential elements that are essential for, obviously, for recognising and responding to acute deterioration. And they're addressed in 2 parts. So Section A deals with the clinical processes that come into play. And these are things like measurement and documentation of vital signs and observations, which is fairly obvious. Having a clinical diagnosis in place early, and this supports timely intervention and treatment for the diagnosis, but also helps when people are trying to determine what might have caused a clinical deterioration. Number 3 is escalation of care. And that's about having protocols in place which outline response strategies. And that might be as simple as starting some analgesia, increasing the frequency of monitoring or observation, escalating to senior nursing staff or medical staff, or more rapid response systems, which is number 4, which is things like medical emergency response teams. So for people who are deteriorating but not in cardiac arrest, or code blues, which are still kind of saved for people who are in a life-threatening situation that we discussed before. And then number 5 is, which is part of clinical, is communicating for safety, which is a standard on its own, but is rolled into this standard as well. And that is all about communicating, because we all know poor communication is usually a contributing factor to most medical negligence cases. So the second part of that 9 essential elements is organisational prerequisites. And this deals basically with the clinical governance side of things. So having good leadership and governance in place to set policies and protocols, having education and training in place to support staff having the right skills, education and qualifications to deliver safe care, having an evaluation, audit and feedback system in place for continuous quality improvement, having systems to support high quality care such as technology. EMRs made electronic medical records have made things a little bit easier in some ways because it's easy to read notes and follow the sequence of care. Sometimes it's made things a little bit harder because it's not always as obvious as paper observation charts, and I'll show you those shortly, which are really obvious when there's things are falling into a reportable zone. So the measurement and documentation of physical observations is essential as a part of the broader system for recognising and responding to acute deterioration. And changes in vital signs tend to occur early in deterioration and late in the deterioration process, but often not in the middle because the body will have some compensation mechanisms in place. And children in particular are really good at doing that. They'll compensate really well for a long time. And when they don't compensate, they deteriorate really quickly, which is a bit different to adults who tend to have often a more predictable course of deterioration. So of regular measurements is obviously important for early recognition. And there's a policy that should outline how frequent documentation should be in people who have just been admitted or have had clinical changes or who are deteriorating, obviously should have more frequent observations. And that while there are set observations for certain clinical conditions, that monitoring plans should be in place for every patient and they should be individualised, and that observations need to be documented clearly in the patient's observation chart, and any variations to those need to be documented in the notes and what's been done about them. So the consensus statement for deterioration led to the development and implementation of new observation and response charts, and they are standardised across Australia now, which means wherever anyone goes, the obs charts essentially look the same. And the observation charts are colour-coded. I'll show you one in a moment. With track and trigger zones for being able to track when things are not trending in the right direction, and then where those escalation trigger points are in terms of colour coding. This does make it decision making a bit more objective because you're able to show where clinical deterioration is occurring and make appropriate clinical responses. So I'll show you the observation chart now. It's a little bit hard to read on here, but on the left-hand side of the screen is over this side here, you've got where the observations are documented. So respiratory rate, oxygen saturations, the level of oxygen that a patient might be on and how it's being delivered, whether it's nasal prongs, face mask. Obviously at the top, date and time is really important, and that's something that time might be documented, but date sometimes is left off the top. Blood pressure is really important to document correctly. Some people will just write the numbers, but it's really important on these charts to actually do it graphically so that you can see the changes in the trends. So heart rate is underneath, temperature, conscious state, and sedation. So sedation is more when people have come into the post-operative area, or if they're having medications that might be sedating, like morphine or something. Otherwise, it's important to note conscious state, because if someone's conscious state has been normal and then it starts to deteriorate, that's obviously an indication that things aren't heading in the right direction. Pain score is also really important as well. Often doesn't get documented. So the colour coding then on the right-hand side is a scale for what the colour coding means. So anything that falls into the yellow zone needs to be escalated to a registered nurse. So it might be the obs are being done by an assistant in nursing, which is not a registered health professional, or an enrolled nurse. And so they need to be escalated to a registered nurse to be reviewed, or potentially to the shift coordinator. And that's basically anything that's in the yellow zone, anything that's new or unexplained in a behavioural change, or basically if the nurse is worried And it has to be escalated if 3 or more observations fall into that zone. It must be escalated to the next level, even if it's not falling into that colour yet. So the red zone is, which kind of looks pink, but it is red, is basically where a registered nurse or a doctor must be reviewing the patient within 30 minutes. So, and they're things like unrelieved chest pain, any observations that are falling in the red zone. If the urine output's been decreasing over less than 30 mils over 4 hours, which is an indication that things are potentially going wrong. Or again, if the nurse is worried and they just want a clinical review, they're allowed to ask for it. And any observations that fall 3 times in the red zone must be escalated to the purple, which is a medical response, or code blue. And that's for respiratory or cardiac arrest, a threatened airway, significant bleeding, any observations, obviously, which are falling into that purple zone, unexpected or uncontrolled seizures. Or if you've called for a red review, a multidisciplinary team review, and nobody's responded in a timely manner, you can then escalate it to a medical emergency response. Or if you're feeling worried enough about the patient clinically and you want an urgent response, then you can call a medical emergency response. And the culture of that has really changed over the last kind of 10, 15 years in terms of it's really an accepted practice now, and you're more likely to get in trouble for not calling it rather than calling it. So obviously when you've found that those observations are in an abnormal area, communication is key. And as I said before, it's a contributing factor in many medical negligence cases. The hospitals should have structured communication protocols in place to support handover and escalation, but handover of information is really critical to make sure that that important information is being passed along to the right people at the right time. So there's lots of different ways that you can do that. One of them is something like ISOBAR, which is a handover tool that's used commonly now, which identifies the patient and the clinical scenario, the situation for why you might be escalating or transferring care, any observations that are relevant, what the patient's background is in terms of their medical history, whether they've got allergies, what significant tests they might have had done, blood tests or scans, an agreed plan of care. And then a readback is making sure that that other person has actually understood the information that's been passed over. So, and the agreed plan of care is really important. Obviously, in the 2 cases that we discussed today, there's been obvious issues related to recognition and response of acute deterioration. And a lot of that came from communication in terms of the documentation and what was passed on to other people or not passed on in these cases. So communication, decision-making and care planning should be shared with the patient and the family to make sure that all of the concerns are being addressed. And this includes listening to and addressing concerns of patients and families. And it also includes providing communication and information in a format that's understood and meaningful. So one thing that I didn't kind of capture in those stories because they're de-identified is that both of them were from non-English speaking backgrounds, or their primary language wasn't English. And so there was some question over whether that played a part in the miscommunication and delay of treatment with both of those young ladies. So from all of this, the National Safety, Quality and Healthcare System standards were put in place. There was 10 standards, there's now 8. They basically set the standard of care that the public can expect when receiving high quality and safe care in Australia. And they set the minimum standard. So hospitals can go over and above that to have better care, but this is the minimum standard that anyone's practice will be judged by if they find themselves in a medical negligence case. And it's basically looking at whether they've failed to provide care to the standards and failed to provide then care to a competent professional level, obviously based on what another reasonable nurse would have done at the same time. So obviously when I'm looking at a case or reviewing a file for medical negligence, often the vital signs aren't monitored at the correct frequency, or they might be incomplete. So like I showed you before in that OBS chart, every single set of observations should include a blood pressure, a heart rate, a respiratory rate, oxygen saturations, temperature, a level of consciousness, a level of pain, and it may also include neurovascular or neurological observations if they've been ordered or are appropriate. Other things that often see when there's been care not provided to a standard is that the vital signs are recorded in the trigger zone, but then they're not escalated. So either whether that be a RN review, a clinical review to a medical team, or a medical emergency response. So it's clear that failure to escalate or recognise life-threatening complications can lead to serious permanent injury or death from things like sepsis, anaphylaxis, opiate overdose, pulmonary embolisms, myocardial infarction, or head injuries post a fall. So just in summary, nurses are the primary caregivers for deteriorating patients, and they play a pivotal role in providing a timely and consistent response in line with hospital policies and procedures to ensure the best outcomes for their patients. And failure to comply with the standards can result in serious injury and death for the patient and a risk of litigation for the healthcare provider and nursing staff. So happy to take questions. Should I stop sharing the screen, Michelle?
Yeah, that's good.
Yeah.
Chrissy, that was fascinating.
Thanks.
So very, very sad, those two
Yeah, they
stories.
really were.
And sadly, we do see that in our business here. As you know, we have a lot of medical negligence matters, and often it's those seemingly simple after the fact observations. One of the key things that I noted you were saying was the importance of doing the observations of the parents' level of concern.
Yes.
And I still remember to this day, my daughter was quite premature, and there were some issues. And I remember the paediatrician saying to one of the nurses, make sure you monitor the mums, because the mums will know almost before anyone else if there's something not right. And at the time I remembered thinking, well, I haven't even known this kid for very long. I mean, it's not even meant to be born yet.
Yeah.
But it's so right that, the parents often do know that there's something not quite right with my kid, and my alarm bells are going off and I need you to do something.
Absolutely. Parents' intuition is really strong. And you find that in most cases where children are involved is that the parents knew something was wrong and they might not have been able to articulate that in a way that, conveyed that concern, but they're concerned enough to bring them in. And no parent wants to sit in ED with their kid for hours and hours if there's nothing wrong. Most don't anyway, but
absolutely not.
Yeah. So it's something that's really important. And even, I think every family member knows their patient better than the nurses do. And so when anyone expresses a concern, and I know in Queensland they have Ryan's rule, and in Victoria we have escalation strategies like that as well. And one of those cases was based in Victoria, and there is some talk about having something similar to Ryan's rule brought into the hospitals for people to be able to escalate care. We do have that in place, but I think it's not advertised well enough to people that there is a number that they can actually call to say, I'm concerned and my concerns aren't being addressed and someone needs to do something. So Safer Care Victoria has had a big role in that.
That's really fascinating. Look, this just come up in the chat. Great talk. Thank you. What do you have to say about the different areas of nursing other than emergency, for example, NICU, maternity and post-operative?
In what respect, sorry?
I'm not sure. This is somebody, MGB. Would you want to elaborate on what you mean by your question? You can unmute yourself and speak, or type it in the chat. Do you mean, are the same pathways the standard of care? So do you mean, are they the same in other areas of nursing? I certainly thought from your talk, Kristi, that they were national standards.
Yeah, they are
the
national.
Same.
Yep. So there are some differences in the standard. Those national standards are adapted basically to all health services, they're adapted on the size and the complexity of the service. So there will be some small differences in terms of protocols for frequency of observation. So obviously on a ward setting, usually obs are kind of 4 hourly. If they're just stable, unless they're post-operative, they're more frequent. Things like ICU, we do obs hourly, same with NICU. Maternity have their own set of observations because obviously post-birth, there's different kinds of observations that need to be done, like, checking the fundus and things like that. So there are some, they do vary slightly, but the actual standard itself can be adapted to any clinical setting. So even community, and we're going and seeing patients sometimes once or twice a week or every day, but we're only in the home for a short period of time, but we still have clinical standards we need to adhere to in terms of monitoring deterioration and escalation, which is important. It's one thing to monitor it, but the escalation part's really important.
Yes. I've got a question here from somebody who wasn't able to attend, and they were saying, do you believe that what the impact of COVID, and I'm guessing that they mean the PPE and all of that went around, the fear of contagion, has had an impact on the standards of care in terms of improving them?
That's a really good question. In terms of improving them, no, I don't. I haven't worked in a hospital setting since COVID's, well, not really, a little bit, but not much, since COVID started. So we have a close association because I work in a smaller regional hospital. So we have a close association with our acute sector. And I think in some ways it's made it harder to be able to deliver as much clinical care, because you've got the donning and doffing of PPE takes time. And when you've got to do that between every patient, it takes away the time you've got to spend with those patients. I think there's always seems to be more and more documentation, and that you kind of got to, spread your time between giving clinical care and making sure you've got enough time to document accurately, because that's obviously important.
Which brings me to the next question it comes actually from a lawyer who was unable to attend. And he asks, is the level of documentation required now, checklists, forms, observations, taking away from the amount of clinical care that nursing staff are able to give? And is the pressure to manage a large patient load meaning that people are forgetting to do that documentation and making errors?
Yeah, absolutely. So I think there seems to be more and more forms to fill in. I know when I do admissions with people, their first comment is always, gee, you have a lot of paperwork to do. So, and there's a lot of information to capture. There's a lot of information to pass to other people in terms of doing referrals and making sure clinical plans are set up and put in place. It does take away from your clinical time. There's no doubt about it. Or you find that you do the clinical care because it's really hard to not do the clinical care. And then you are running late from leaving work because you're trying to get all the documentation done, or the documentation gets done poorly because you're time poor.
Yeah,
so
that's true.
Yeah. And what was the other part of the question? Was
the increased patient load impacting that?
Yeah. So we're really lucky in Victoria that we've got mandated patient ratios in the public sector. And that really helps, because in the private sector, they don't exist. They don't exist in aged care either. Yes. And so it's very much driven by management deciding how many nurses they should have on for patient load. And the patient load, you might have 10 patients on a night shift, but those 10 patients might all be stable. And so your night is not too bad. Or 8 out of those 10 might be post-operative and you're needing to do half-hourly obs on them for 4 hours. And that can completely change your night. And I don't think that's always factored in from management when, the complexity of those 10 patients might be completely different, or 6 patients or 4 patients or however many you're looking after. So yes, it does impact it, definitely.
And finally, a last question, because I'm conscious we need to wind this up.
Yep.
So and we're talking about a nurse here, because that's what you are and that's what you were speaking about. Yep. When a nurse identifies a deterioration, the second part of that is to know which clinical pathway to initiate. Do I call for a neurological consult? Do I escalate to this level? Do I go to my senior? So how well do you think those pathways and points of escalation are documented and made clear so that people are taking the right pathway?
Yep. Some places do it really well in terms of you will always escalate initially to the admitting team. So there's often patients are complex and they might have, 4 or 5 or 6 teams involved. So the first point of call is always going to be the admitting team. And I think that's made pretty clear in terms of you would call that team first. And then if you weren't getting a response from that team, you would then escalate up the ladder for that team. So you would usually call for a review from like a resident or a registrar And then if you didn't feel that that was appropriate, you would escalate up to, say, the consultant. If you weren't getting a response, then you would escalate to your manager, who would then take it further and maybe go to the medical director or go to another consultant that might be involved in the level of care, in that patient's care, to provide an appropriate level of response. So I think the pathways are, some places do it really well. Some places don't have, it's harder in private hospitals because you're usually going straight to the consultant. And honestly, sometimes they don't want to be disturbed if they feel like you're maybe overreacting to something that they might think is not clinically significant. But that nurse's intuition, there's always an objective thing that you're feeling, even if it's just that gut feeling. There's something that you're seeing or registering. And so I think some places do it better than others, but I think it's a lot better than it used to be.
Right. Thank you for that. Look, that was really, really excellent. I know this is going to get a lot of views on our YouTube channel, so I'm really pleased about that. We need to wind up now. So thank you, everybody, for making time to join us today with Kristi Gilbert, failing to recognise and respond to clinical deterioration. It was outstanding. As I said, the recording will come to you all within about a day. And if there's other seminars or other specialists or other topics that you even like to hear from Kristi, please let me know, because we really do enjoy providing this service to our clients, and it's a great way for you to see our wonderful specialists as well. Thanks, everybody, and have a great rest of the day.
Thank you.
Bye.